Hello, and thank you for joining us for this segment where we will be discussing again assessing risk in patients with pulmonary arterial hypertension, and is it time to introduce risk scoring in our patient management? I'm Sean Studer, an associate professor of medicine at SUNY Downstate Medical Center in Brooklyn, New York, and I'm joined today by two colleagues, Dr. Paul Forfia from Temple University in Philadelphia, and Martha Kingman from University of Texas Southwest in Dallas, Texas. Thank you both for joining me.
Thank you.
So I wanted to ask you, and I'll start with you, Paul, do you think there's an important aspect of the risk scoring that's relatively consistent across the different tools? Because of course, there were different ones from the REVEAL registry, the French registry, the Swedish pulmonary arterial hypertension registry, that sort of reflect the most important aspects of what we assess in our patients?
I do. I mean, I think that, we have to understand that the risk metrics that have been applied differ depending on the studies that are done, but the pathophysiology of pulmonary arterial hypertension remains the same. And so I think that we know that the core pathophysiology of PAH is a constricted, remodeled pulmonary vascular bed that imposes excessive afterload on the right heart. The right heart cannot liberate a cardiac output that is either appropriate at rest or with exertion. And patients have circulatory limitation with exercise related to this phenomenon between their heart and their lung circulation. And so at the root of the disease is this abnormal relationship between the heart and the lung vascular bed. And so when we talk about functional capacity, when we talk about the walk distance or the BNP level, all of these are metrics. The right heart catheterization and its various parameters, cardiac index, right atrial pressure, right heart size and function on an echo, all of these things are emanating from a core physiology of this abnormal relationship. And the clinical expression of PAH is that of an abnormal right heart. And so I think it's important for the clinician who's using these risk scores to understand what is at the core of poor functional capacity, a low walk distance, a high BNP level, it's abnormal RV function. And what's at the core of improving functional capacity, a rising walk distance, and a falling BNP is improving RV size and function. And so I always keep that in mind when I'm considering one version or another of a risk score, as I'm always kind of trying to find that center, go back to that pathophysiology of the disease first and foremost, and then use the risk metrics thereafter.
Thank you. That's a great summary. Maybe that's in some reason why it underpins the French non-invasive risk assessment that was really quite simplistic, right? It was 6-minute walk distance, functional class, and NT-proBNP or BNP. So rather rudimentary 3 factors that were fairly highly predictive. And many of the risk strategies had many more parameters, and of course there's different ways to evaluate patients visit to visit. But I think what's also interesting to me about some of the risk scoring systems is that they have limitations, not necessarily of just too many parameters, right? There's as many as 12 in the REVEAL calculation, but there may be some things that are underrepresented. I mean, Martha, do you have things that you use in your practice that you feel are not perhaps well represented in the risk scoring?
Well, we do. And of course, the echocardiogram, as Paul mentioned, for years we've thought and still believe that it's all about the RV. The size and function of the RV need to be normalized or near normal. But if you look at the risk score calculators that we have, they don't mention the RV size or function. But of course, we're still looking at that, and we do an echocardiogram at least every 6 months. And then in our practice, we do cardiac MRIs every year as well, just to get an even better look at the RV size and function. So it's kind of surprising that they're not actually in the calculator, but I think remain very important. And another thing that's not in there is the patient perspective. So there's nothing in there really about the patient goals, and that's something that we're trying to incorporate more as well, focusing on quality of life and things like that, palliative care, and trying to get those things incorporated in their goals as well.
Thank you. Those are some really great points. And I think what it emphasizes is that if someone were to get very concerned about differences between risk calculators, it's best to remember in part what Paul was describing about its reflection of the underlying pathophysiology and how you view those through which lens, which parameter, and perhaps the things it doesn't represent, that it's not the be-all and end-all, that our composite evaluation of patients are likely going to include some things that don't fit neatly into current risk calculators. So I think it was a very rich discussion, and I appreciate that. Thank you so much for joining us for this segment.